Welcome back to this next video in which we are discussing cardiac arrhythmias. Okay, so we've now talked about cardiac arrhythmias which arise because of problems with the sinoatrial node. What we're now going to talk about is cardiac arrhythmias which arise because of problems with the atria. Okay, and we're going to start off by talking about atrial ectopic beats, then we'll talk about atrial flutter, and then finally atrial fibrillation. Okay, so cardiac arrhythmias then that arise because of problems with the atria. So as I say, the first thing we need to talk about is atrial ectopic beats. So I'll write that as the title here. So we'll start off with, I'll write it as a separate title, atrial ectopic beats. Okay, so firstly, let me describe what is going to happen with atrial ectopic beats, and then what we'll do is go on to how it can be treated if necessary. Okay, and often it won't be necessary to treat atrial ectopic beats. It will obviously depend on how severe it is. Okay, right, so what is the principle of what happens with atrial ectopic beats? So the idea here is that you end up with what's known as an ectopic focus. So ectopic, you might know the meaning of that word from ectopic pregnancy. It means something occurring in the wrong place. Okay, an ectopic pregnancy is where the embryo implants into the incorrect portion, generally into the fallopian tubes. Okay, ectopic beats are pacemaker activity in incorrect places. Okay, so it's going to arise from an ectopic focus. Actually, I was meant to be writing down ectopic focus, not ectopic beats. Okay, so the key concept then is an ectopic focus. So an ectopic focus is a portion of the myocardium that is going to take on pacemaker activity, even though it shouldn't. So we know that the sinoatrial node should be driving the heartbeat. Okay, it has this pacemaker activity, it generates an action potential approximately every 0.8 seconds. What happens in atrial ectopic beats is that we're going to get ectopic foci, which is just the plural for ectopic focus, in the atrial cardiomyocyte tissue. Okay, so somewhere in the atria we are going to get a cardiomyocyte, or potentially a cluster of cardiomyocytes, that are going to say, we fancy having the job of the sinoatrial node cells. Okay, and they're somehow going to end up with the ability to generate action potentials on their own. So that's the key here, that portions of the myocardium that should not have pacemaker activity are suddenly going to gain the ability to have pacemaker activity. And if it's atrial ectopic beats that we're talking about, the portion of myocardium that has gained this ability to actually generate action potentials from scratch is going to be somewhere in the atria. Okay, so if I go back to my picture of the way here, somewhere in the either the right atrial tissue or the left atrial tissue, we are going to end up with, oops, it's on a horrible angle, if somewhere in the right atrial or left atrial tissue, we are going to end up with one of these ectopic foci, or potentially multiple of them, which are now going to take on pacemaker activity. Okay, so we're going to still have the sinoatrial node generating action potentials at its normal rate, but on the side we're now going to have this ectopic focus also spitting out electrical signals from time to time. So what will this actually look like on the ECG? Well, how it looks on the ECG is going to depend on where the ectopic focus is. Now let me explain why. If the ectopic focus is very high up, near where the sinoatrial node is, then when it generates an electrical signal, the electrical signal will still propagate in the normal direction, i.e. from the top down. Okay, so the cardiac vector, the direction in which the electrical signal will propagate, is still the normal direction. Okay, and for that reason, when you have a P wave that's resulting from this ectopic beat, this beat of the heart due to the electrical signal generated by the ectopic focus, it will still be the normal way round when we're looking at a lead 2 ECG. Whereas, if our ectopic focus was further down, let's say right at the bottom, let's go to the opposite extreme. If it was right down at the bottom of the atria, then when it generates its electrical signal, yes, the electrical signal will go off to the ventricles, but then it will also go back up to the atria, and it will have to go in the opposite direction, so the electrical signal will propagate in the opposite direction. The cardiac vector will be pointing upwards. That's known as retrograde conduction in the atria. So anterograde conduction, I'll put these key words down here. So anterograde conduction in the atria means conduction downwards in the normal direction. What we will get if the ectopic focus is low enough is we'll get retrograde conduction in the atria, where the electrical signal is going to actually conduct in the opposite direction. And what's going to happen on the ECG if that's the case? If the cardiac vector is pointing in the opposite direction, of course we're going to end up with a P wave that is inverted. Okay, so some of these ectopic foci, if they're far enough down, will actually lead to a inverted P wave on the ECG. Okay, so depending on where the position of the ectopic focus is, this will determine whether the P wave for the ectopic beat on the ECG is actually the normal way up or whether it's inverted. And you can imagine that if it's in the middle, what's going to happen is we're going to get some anterograde conduction downwards, but we'll also get some retrograde conduction, and they might actually balance each other out, so you might not get a P wave at all. So depending on the position of the ectopic focus, the P wave of your ectopic beat on the ECG will look different. Okay, so let me draw then what the ECG for one of these ectopic beats will actually look like. And we'll do one of the dramatic ones where it's down at the bottom. So you could end up with a lead 2 ECG for your ectopic beat looking something like this. An inverted P wave because the electrical signal is propagating in a retrograde fashion up the atria, and then we'd have a normal QRS as it propagates down to the ventricles, and then a normal T wave because ventricular repolarization is absolutely fine. So it's just the P wave that can look very odd on the ECG for these ectopic beats. Now, of course, if we were to follow the ECG for a longer period of time, this is just the ECG for the ectopic beat. You'd also have normal beats in amongst the ectopic beats, okay, because the sinoatrial node is still sending out electrical signals, and their beats will be perfectly normal on ECG. So these will just appear amongst all the normal beats. So if you're looking at the ECG over a minute, you'll have lots of normal beats, normal ECG patterns, and then just scattered amongst them you'll have these ectopic ones which have the odd P wave. And as I say, depending on the position of the ectopic focus, the P wave will be distorted in different ways. It might just be a small P wave if it's not quite as high up as the sinoatrial node, the ectopic focus. You might have a quite flat P wave if it's sort of in the middle, and potentially an inverted one if it's far enough down that the main electrical signal conduction up, within the atria is retrograde. Okay, so there's the ECG then for an atrial ectopic beat. Okay, so how severe is this? Well, of course, the severity of this really depends on how many of these ectopic beats you're getting. If you're getting a huge number of ectopic beats every minute, then this could lead to the atria contracting at a huge rate, and if those electrical signals are all passed on to the ventricles, then we could end up with the ventricles contracting at a massive rate, and that of course will cause tachycardia, which is quite a severe arrhythmia if it's dramatic enough. Okay, so remember, we know that if the heart, if the ventricles are being told to contract too rapidly, they don't get to relax enough, and therefore they end up just doing a shudder basically and won't actually be ejecting that much blood at all, which is very dangerous. Okay, so obviously the severity of this is completely determined by how often these ectopic foci are sending out their action potentials. And by the way, if you're wondering what's the mechanism of these cardiomyocytes actually gaining this ability to generate action potentials, that's still very controversial and not very well understood, which is why we're not going into that. Okay, so again, we're going for the cellular level rather than the molecular level. We're not going to actually look at the molecular mechanisms by which these ectopic foci of cardiomyocytes are actually generating electrical signals. Okay, we're just doing it on the cellular basis. We know that they do. What's the effect on the heart? Okay, right. So if this is severe enough to warrant treatment, then what are the actual treatment strategies? Okay, so let me just get another piece of paper and we'll go into the treatment. So the first option that I want to explain to you is non-drug treatment, and then we'll go on to the drug treatments. Okay, so treatment then for this. One of the key ways that we now treat ectopic foci is with what's known as catheter ablation. Now, catheter ablation is a technique that can be used for other things beyond just getting rid of ectopic foci within the heart, but here obviously we'll just talk about it with regards to getting rid of ectopic foci in the heart. Okay, so catheter ablation, this is the basic idea. A catheter is just a tube, and of course you can insert something up the tube potentially. Okay, so what's going to happen is in catheter ablation you're going to feed a tube from some blood vessel that's easy to gain access to. So generally people can use the radial artery in the arm or the femoral artery in the leg. So you'll go in through one of these easy to access arteries in the circulatory system, and then you'll guide, which, you know, goodness knows how they do this, but surgeons, cardiovascular surgeons, are capable of then guiding the catheter back up through the circulatory system. I think with the femoral artery it's quite simple because you just literally follow all the blood vessels back up. With the radial artery it's probably more complicated because the circulatory system getting to the radial artery is more complicated. Okay, but you guide your catheter up the circulatory system and back into the heart, and then the idea is that what you can do is you can find your ectopic focus, if you know where the ectopic focus is, and you can destroy that ectopic focus. So general ways in which this is done is you can either heat up the ectopic focus or you can cool it down. So up through the catheter you will insert some means to heat up your ectopic focus or cool it down, and that will result in its destruction. So the idea is that you kill the ectopic focus so that it's no longer going to be generating these ectopic beats. Okay, so catheter ablation then of the ectopic focus is an option for treatment of atrial ectopic beats. Now let's talk about drugs that can actually be used to treat this. Okay, so firstly what I want to do is give you the overall principle that both of the categories of drugs that I'm going to tell you about that can be used here are going to work with. Okay, so this is the principle. We know that the important chambers of the heart are the ventricles. The atria are not that particularly important. We want to make sure that the the ventricles are not going to beat at too high a rate. We want to prevent tachycardia. The atria are beating at far too high a rate, let's say, because we've got these atrial foci, potentially multiple of them, that are generating ectopic beats at far too high a rate. So we've got the atria undergoing contraction at a massive rate. If we can block all of those, well, quite a few of those electrical signals from actually getting down to the ventricles, then it's not going to be a problem. It's not a problem if the atria are contracting at a massive rate, as long as the ventricles are not contracting at a massive rate. Okay, so what we could do with doing then is stopping the atrioventricular node from conducting all of these electrical signals down to the ventricles. So here is my picture here. So we've got the atria undergoing or conducting electrical signals at a massive rate and contracting at a massive rate. If we can make sure that the AV node only passes a reasonable number of these electrical signals onto the ventricles, i.e. not all of them, then we can hopefully stop the ventricles from actually gaining a tachycardia from contracting at this far too high a rate, which is what's actually pathological. Okay, we don't want the ventricles to contract at far too high a rate because that can then lower the ejection volume hugely. Okay, so the idea then behind both of the categories of drugs that I'm going to tell you about that we can use for atrial ectopic beats is all about trying to stop all of the electrical signals that the atria are generating being conducted down to the ventricles. And how can we do this? Well, the principle is that we can do it by slowing down conduction through the atrioventricular node. Now let me explain why slowing down conduction in the atrioventricular node is going to mean that not all of the electrical signals are actually going to be conducted from the atria to the ventricles. Okay, so let me just draw another picture on another piece of paper here. So let's say we have an atrioventricular node cardiomyocyte here. Okay, so this is an AV node cardiomyocyte. Okay, it is receiving, let's say, stimulation from a cardiomyocyte of the atrium up here. Okay, now, when it receives stimulation from the atrial cardiomyocyte, it's going to conduct an action potential along its length to the other side, and then it will pass it along to the next cell along. Okay, now, in order for it to then conduct another one, the signal has to have gotten a certain distance down this atrioventricular node cardiomyocyte. So let me just remind you of the principle of saltatory conduction. So the principle of saltatory conduction is that when this cardiomyocyte from here, the previous cardiomyocyte stimulates this one, you will get an action potential initially occurring at, let's say, this portion of membrane that I've coloured in red here. When that undergoes an action potential, it will stimulate then the next portion of membrane along, which is the portion that I've got coloured in orange here. When that portion undergoes an action potential, it will trigger the next portion along to undergo an action potential. And remember, the reason that this is occurring is because every time a portion undergoes an action potential, its electrical potential difference across the cell membrane is hugely depolarized, and that is done by bringing in positively charged ions into the cytoplasm of the cell, hence raising the electrical potential intercellularly. These positively charged ions then move over to the neighbouring portions and depolarize the electrical potential difference across that portion of the cell membrane. Okay, and in this way, the electrical potential the action potential is going to propagate along the cardiomyocyte, and that's the principle of saltatory conduction, which just refers to a domino-like effect of action potential here causes an action potential here, causes an action potential here, etc. Okay, now, once this portion has undergone an action potential, it will then start to recover. So in the wake of the action potential, the membrane is starting to recover. So the action potential propagates along via this saltatory conduction mechanism, and in the wake of it, in the portion of membranes that have now undergone the action potential, they're starting to recover, and they're starting to go back into a state where they could be stimulated to undergo another action potential by the neighbouring cardiomyocyte again. However, in order for this membrane to fully recover and be ready for another action potential, be ready to conduct another action potential if it gets stimulation from the atrial cardiomyocyte here, the action potential needs to have gotten a certain distance away from it. Because remember, when, let's say, this green portion of membrane here is undergoing an action potential, it's hugely electrically disturbed here. Okay, you've got the electrical potential inside the cell hugely raised because of the positive charge coming in. That will still be influencing the electrical potential inside the cell over here. So if this truly is going to go back to being in the resting state, i.e. if it's truly going to go back to its resting electrical potential difference across the cell membrane, below threshold potential, where it will then be able to get its voltage-gated channels back into their resting state. If it's truly going to recover, it needs this action potential to have gotten a certain distance away from it. Otherwise, it's not going to be able to recover, because where the action potential is occurring, you're getting these disturbances to the electrical potential intracellularly, and those are going to have effects over here, okay? So until the action potential has got far enough away, then this membrane cannot truly have recovered, and it can't yet conduct, it can't yet have another action potential occur over it, even if the cell previous to it is trying to stimulate it to undergo another action potential. Okay, so I hope that I've got my message across there, that in order for this cell to now be stimulated to conduct another action potential, you need the first action potential to have gotten far enough along this cell so that it's no longer disturbing the electrical potential difference across this portion of the membrane, and therefore the electrical potential difference across this membrane is back below threshold potential, so that the voltage-gated ion channels are back in their resting states. Okay, so if it was the case that this previous cardiomyocyte was trying to stimulate this membrane before the action potential had got far enough away that this membrane was back in the refreshed resting state, then it wouldn't work. Okay, you wouldn't successfully get this cardiomyocyte of the AV node to actually fire another action potential. I wouldn't conduct that electrical signal. Okay, this is the basic principle that we're going to be working on. So the AV node conducts electrical signals from the atria to the ventricles. However, it can only conduct a certain number of them, okay, because of the fact that it will only be able to be stimulated again to fire another action potential, to propagate another one through, once the first one has got far enough away from it. Okay, so what are we trying to do? Go back to what we're trying to do. The atria are undergoing action potentials at far too high a rate. We want to try and make sure that not all of these, or at least we want to try and make sure that fewer of these are going down to the ventricles, okay, so that we're getting a normal number of action potentials actually being delivered to the ventricles. How could we do that? Well, if we were to slow the conduction of the action potential along the atrioventricular node cardiomyocytes, then obviously it would take longer for the action potential to get far enough away from this initial portion of the membrane that the initial portion of the membrane has recovered and can now be stimulated to undergo another action potential. And that will mean that the maximum rate at which action potentials can be conducted through the atrioventricular node from the atria to the ventricles is actually going to be reduced, and hopefully then we can stop the atrial tachycardia actually resulting in a ventricular tachycardia, a true tachycardia. Okay, so that's going to be our strategy. Slow down the conduction of action potentials in the AV node. That will then mean that the maximum rate at which electrical signals can be propagated from the atria to the ventricles is reduced. Okay, therefore, even if the atria are contracting at a massive rate, have got massive rates of electrical signals propagating through them, not all of these are actually going to be conducted to the ventricles. A lot of them will be blocked and they'll just result in atrial activity but no ventricular activity, and then the ventricular rate will be more normal, and that will mean that we still will actually get a respectable ejection volume from the ventricles, and that will keep you alive. Okay, so that's going to be our strategy, to slow down conduction in the atrioventricular node cardiomyocytes. So, how can we slow down conduction in the atrioventricular node cardiomyocytes? Okay, well, go back to our physiology. There was a way of speeding up conduction in the atrioventricular node cardiomyocytes, which was to stimulate the AV node cardiomyocytes with beta-1 adrenoreceptors. Okay, so to stimulate them with noradrenaline or norepinephrine, depending on what you want to call it. Okay, so all the time, the sympathetic nerves on the heart, we've discussed this, are releasing noradrenaline or norepinephrine onto the cardiomyocytes of the heart, and this is called sympathetic tone, and it's activating beta-1 adrenoreceptors. And those beta-1 adrenoreceptors on AV node cells are keeping conduction of action potentials reasonably fast. If we were to lower sympathetic tone, if we were to block sympathetic tone, then they no longer have that stimulation, and that would actually result in the conduction of action potentials in the AV node cardiomyocytes going down, and that would mean that the maximum number of action potentials that can be conducted through the AV node in a minute would go down. Okay, so how do we stop the noradrenaline or norepinephrine from stimulating beta-1 adrenaline receptors? Well, of course, we use beta blockers. Okay, and I've already given you the names of these, so we could use a non-selective beta blocker, which will block beta-1 and beta-2. It's not really necessary because we're not interested in blocking beta-2 receptors, but you could use one of those, such as propranolol. Or you could use a beta-1 selective beta blocker, such as atenolol or metoprolol. Okay, so beta blockers are going to slow the conduction of action potentials along the membranes of a single atrioventricular node cardiomyocyte, and that's now going to mean that the number of action potentials that the AV node can conduct through it from the atria to the ventricles in a minute is going to be reduced, and hence, hopefully, we can stop this atrial tachycardia causing ventricular tachycardia, which is real tachycardia, and therefore we can keep the ejection volume up. Okay, another category of drugs that is also going to slow down the conduction of action potentials along an atrial ventricular node cardiomyocyte are the calcium channel blockers, okay, often called the CCBs. Now this is a whole other category of antiarrhythmic drug, and as I say, at the end of the video I will talk about the Vaughan-Williams classification. Those of you who know something about that already will know that beta blockers, they are classified as Vaughan-Williams category type 2, okay, and the calcium channel blockers are Vaughan-Williams class 4 antiarrhythmic drugs, but we'll come back to that all at the end. Okay, so CCBs. So in order to explain how CCBs actually result in slowing of the conduction of the action potential along atrioventricular node cardiomyocytes, we're going to have to study the action potential of AV node cardiomyocytes in a little bit more detail, and we're going to have to talk about it in a level of detail that people don't usually talk about it. Often people simplify it, and indeed in previous videos in this playlist on the cardiovascular system, in particular in the video on the cardiac cycle and cardiac electrophysiology, I simplify the action potential in atrioventricular node cardiomyocytes. What we're going to have to do is study it in a little bit more detail than is usually done in order to understand how these drugs are actually going to work. Okay, so we'll just go through that. But firstly, let me just write down what CCB stands for: calcium channel blockers, and I'll go through the different examples of calcium channel blockers after we've actually been through a reminder of the action potential in AV node cells. Okay, so let me remind you of how the action potential actually works in AV node cells. So firstly, I'll start by drawing one of these graphs for electrical potential difference. So as usual, the x-axis will be time, and this will be the electrical potential difference across the cell membrane. And I don't think I'll try and do it on that picture, so I'll draw the cell membrane here. So let's just say this is a little piece of cell membrane from my atrioventricular node cardiomyocyte here. Now, the electrical potential difference across the cell membrane of an atrioventricular node cardiomyocyte generally starts off at around negative 65 millivolts, the sort of classical level. Negative 65 to negative 60, that sort of region. We'll just go for negative 65. Okay, right. So the first portion of the action potential is going to arise because of stimulation by either the previous cardiomyocyte, so the cardiomyocyte here, if you're this portion of the membrane, or if you're further along portion of the membrane, it will come from depolarization because of positive charge moving over from a neighboring portion of the membrane. Atrioventricular node cardiomyocytes, they do have HCN channels and are capable of automaticity, but usually remember they're in auto-drive suppression. Okay, so long before the HCN channels have had any effect on the electrical potential difference here, you'll be getting depolarization due to positively charged ions coming from a neighboring cell or from a neighboring portion of membrane. Okay, so the first phase of the AV node action potential looks like this, and it will generally depolarize you up to something around negative 50 millivolts. Okay, and this is due to a positive charge coming from either a neighbouring cell through gap junctions or from a neighbouring portion of the membrane. Okay, so this is the initial depolarization portion. Then at negative 50 millivolts, that's actually going to drive a certain type of calcium channel to open, which will help to depolarize the electrical potential difference across the cell membrane further. Okay, so let me now draw this calcium channel here. So this is called the T-type voltage-gated calcium channel, and this is the simplification that people often make. We often, to simplify the action potential in AV node cells, and indeed in sinoatrial node cells, just focus on the T-type voltage-gated calcium channels to get people to remember the importance of T-type voltage-gated calcium channels in these cells. However, the T-type voltage-gated calcium channels, their actual part in this action potential is much smaller than another type of voltage-gated calcium channel, which is the L-type voltage-gated calcium channel. Okay, so let me now tell you the true role of the T-type voltage-gated calcium channels in AV node cells. So once you've got to negative 50 millivolts, these open. Now that's a low threshold potential. Usually voltage-gated ion channels have a higher threshold potential. Usually you have to get up to negative 40 millivolts before a voltage-gated ion channel will open. But these ones, they open at this low threshold potential of negative 50 millivolts, long before the L-type voltage-gated calcium channels would. They have the more normal threshold potential of negative 40. Okay, and when they open, of course, you've got a massive calcium gradient across the cell membrane. Generally, extracellular calcium's around 1.5 millimolar, whereas intracellular calcium's more around 100 nanomolar. That's a 15,000-fold gradient, favouring the movement of calcium into the cell. So when you open a calcium channel in the cell membrane, you don't even need to think about what the electrical potential difference across the cell membrane is to work out which direction calcium is going to move. It's going to move into the cell always. There's going to be a net movement into the cell. Okay, so T-type voltage-gated calcium channels will open, and you'll get calcium moving into the cytoplasm of the cell, and this causes a little bit of a depolarization upwards. But these are called T-type voltage-gated calcium channels for a good reason. The T is for transient. They are open for a very short period of time, and then they will start to close. Okay, they'll start to inactivate. So already, just after that tiny little depolarization they produced there, they're now starting to close. Okay, but luckily, what we've got up to is negative 40 millivolts. So bringing in the calcium ions, of course you're bringing in positive charge, making the electrical potential intracellularly higher, lowering the electrical potential extracellularly because you've dragged those calcium ions from extracellular to intracellular. Okay, well, you haven't dragged them, but you've moved them. So moving them away from the extracellular compartment lowers the electrical potential extracellularly. So now what's going to happen is that's overall going to depolarize the electrical potential difference across the cell membrane. It's going to make it less negative. Okay, and the result is that it moves the electrical potential difference up to negative 40 millivolts, which is now the threshold potential for the more normal voltage-gated calcium channel, which is the L-type voltage-gated calcium channel. Okay, so here comes the next really important type of voltage-gated calcium channel. So I have this one in green, and this is the one that does the main portion of the upstroke of the action potential in these AV node cells. To simplify things, often we say it's just the T-type voltage-gated calcium channel that's doing the major upstroke, but it's not. It's the L-type one that does the major upstroke. Okay, so here is the more, well, closer to the truth. Of course, this is still just a cartoon model of what's really happening inside your atrial ventricular node cardiomyocyte, but this is closer to the truth than the more simplistic model that I present in the video on the cardiac cycle and cardiac electrophysiology. But without this more in-detailed model, we can't hope to understand the mechanism of these calcium channel blockers. Okay, so the L-type voltage-gated calcium channels now open, and of course they're going to allow calcium to come into the cell. That will depolarize the cell membrane further, and what now happens is it goes on and on and on. So these stay open for a much longer time, and they have a much larger conductance of calcium. So the T-type voltage-gated calcium channels, they stay open for a very transient time, and their conductance of calcium, so the actual ability of these to conduct calcium through them, is much lower than the L-type voltage-gated calcium channels. So if you have two of them open for exactly the same amount of time, more calcium will come through this one than this one, just because it's better at actually conducting the calcium ions. Calcium ions prefer going through this one to this one. Okay, so they cause a more rapid upstroke of the action potential here, and they actually depolarize the electrical potential difference across the cell membrane up to positive levels, so where the electrical potential intracellularly is actually going to end up greater than the electrical potential extracellularly. You're going to step up in electrical potential by crossing the cell membrane. So you go up to plus 15 millivolts here, and then the L-type voltage-gated calcium channels start to inactivate and close. Okay, so the L-type voltage-gated calcium channels are responsible for the major upstroke of the action potential in these atrioventricular node cardiomyocytes. And then, of course, let's just go through repolarization now. What will happen is the voltage-gated potassium channels will open, and these, of course, were activated to open at around the same threshold potential as the L-type voltage-gated calcium channels. So when you got to negative 40 millivolts here, the normal threshold potential, that's the point where the voltage-gated potassium channels would have been activated to open. It's just they're much slower at actually getting around to opening. Their opening kinetics mechanism takes a lot longer than for the voltage-gated calcium channels, so they've only just got around to opening at the time once the L-type voltage-gated calcium channels are now inactivating. And of course, when they open, they're going to allow potassium ions to move out of the cell, because potassium is much higher inside the cell at a concentration of around 155 millimolar compared to an extracellular concentration of around 4 millimolar. So you've got about a 40-fold concentration gradient of potassium favouring the movement outwards. You'll now be moving positive charge outwards, lowering the electrical potential intracellularly, raising the electrical potential extracellularly, and therefore making the electrical potential difference across the cell membrane more negative. So now what will happen is that will bring the electrical potential difference across the cell membrane back down to around negative 65, and then of course the voltage-gated potassium channels will close. Either they'll have closed up here because they've inactivated, or if they're closing down here, it will be because they're deactivating, because we're back below the threshold potential. Those that did inactivate up here potentially will then de-inactivate and deactivate, so they'll undo the inactivation closure and they'll then deactivate once you're back into negative 40 millivolts. The same for the voltage-gated calcium channels of both types. They'll start to de-inactivate and then go back into the resting state. Okay, so there is our sinoatrial node action potential here. So that's, no, sorry, not sinoatrial node, AV node action potential here. Okay, right. So we've now gone over that. Let's now talk about the basic idea with what calcium channel blockers are going to do and how they're going to slow down the action potential, and then I'll talk about the different examples of calcium channel blockers. Okay, so this is the basic principle of how these drugs are going to work to slow down the action potential conduction. We are going to give a drug which binds to and blocks the L-type voltage-gated calcium channels. Okay, so we're going to take out a whole bunch of L-type voltage-gated calcium channels. Now, we will not give the drug in a high enough dose that it blocks all of the L-type voltage-gated calcium channels. Clearly, if we did that, it would cause big problems. All we want to do is block a fraction of them, okay? So a good fraction of them we are going to block. Now, what will that actually do if you block a good fraction of them? Well, it will mean that the actual depolarization you're going to get here in the action potential will be lower. So it might now instead look something like this, your action potential. Okay, you might not depolarize quite up to the same level as before because the number of functional L-type voltage-gated calcium channels without the drug bound to them is reduced. Okay, is that a problem? Well, no, the action potential has still got its overall form, it's still working. Go to the saltatory conduction now. So the important property of an action potential is this saltatory conduction. After all, what's the point of action potentials? To send signals, okay? So we need the action potential to be able to conduct to the neighbouring portion of the membrane. If you have reduced the amount of calcium that is coming in the upstroke, which indeed we have, then the amount by which the electrical potential intracellularly has been disturbed is reduced. What this is going to mean is that the amount of membrane space that you are able to jump is going to be reduced. So let me explain what I mean by that. When we have this saltatory conduction, let's say this portion of membrane here is undergoing an action potential. It's bringing in positive charge, okay? This positive charge is going to diffuse or move to the intracellular compartment under this neighbouring bit of cell membrane. How big is that portion of the membrane? Well, of course, that's going to be determined by how much positive charge you've got here. If you've got loads of positive charge here, then the influence of this, the depolarizing influence of this, is going to be further than it would if it was a small amount. Okay, so how far you will actually be able to induce an action potential, i.e. whether it's going to be a massive great portion of membrane like that that's now going to undergo an action potential just because we've had an action potential in this blue spot, or whether it's going to be a tiny little portion of membrane, that's determined by how much positive charge you bring in. If we have reduced the amount of positive charge that is coming in when this blue portion of membrane undergoes an action potential, then the spreading influence of this is going to be reduced. You're only going to spread to a very small neighbouring patch of membrane, and then when that undergoes an action potential again, it'll bring in a very small amount of positive charge now because of the calcium channel blocker, and then it'll just spread to the neighbouring small portion of membrane. Whereas before, when the amount of positive charge we're bringing in was greater, you could spread to a larger patch of cell membrane, and then when that one spread, it would spread to a larger patch of cell membrane. So the speed at which you covered the entire cell membrane would have been greater when the amount of positive charge that you were bringing in the upstroke of the action potential was greater. So I hope you understand why, if we reduce the amount of positive charge that we bring in the upstroke of the action potential, the speed at which saltatory conduction is going to cover a certain portion of membrane is going to be reduced, because when you activate the neighbouring portion of membrane to undergo an action potential, how large, how far that neighbouring portion of membrane that's going to be activated extends for is determined by how much positive charge you've brought in. If you bring in a lot, then you're going to be able to influence far away portions of membrane, and all of that is now going to be induced to undergo an action potential just because of you. Whereas if you bring in a lot, then it's going to just be a very small packet of membrane next to you that's going to be induced to undergo an action potential, and therefore it's going to take you much longer to cover the same amount of membrane, because you're going to have to do it in loads of different saltatory conduction steps rather than just all in one. Okay, so that's why reducing the amount of positive charge that is coming in the upstroke of the action potential is going to slow down saltatory conduction, slow down the conduction of the action potential through these AV node cells, and we know that if we do that, we slow down or reduce the rate at which action potentials can be conducted from the atria to the ventricles. Okay, so now time for the names of drugs. So which calcium channel blockers do we actually use here? So they're going to be Ltype voltage-gated calcium channel blockers, not Ttype voltage-gated calcium channel blockers. A lot of these drugs do also have a bit of an effect on blocking Ttype voltage-gated calcium channels, but when you look up in textbooks how these drugs actually have an anti-arrhythmic effect, everyone talks about their effects on Ltype voltage-gated calcium channels, so we'll focus our attention there. So there are three categories of Ltype voltage-gated calcium channel blockers, which are the dihydropyridines. So these are all very famous drugs. So dihydropyridines, okay, and I'll give you examples of dihydropyridines in a moment. The next category of calcium channel blockers are the phenylalkylamines, okay, and then the final category of L-type voltage-gated calcium channel blockers are the benzodiazepines, not to be confused with benzodiazepines. They have a very different effect. Okay, so benzodiazepines. Okay, right. And of course, these names are all determined by their chemical structures. Okay, so these are all chemistry names here. Okay, so dihydropyridines then, these are not going to be used as antiarrhythmic drugs. Okay, dihydropyridines are drugs like nifedipine, and another famous example is amlodipine. They are typically used to treat things like essential hypertension. Okay, and the reason they are so good at treating hypertension is that they block L-type voltage-gated calcium channels particularly well in smooth muscle cells, in vascular smooth muscle cells. They are not very good at blocking L-type voltage-gated calcium channels in cardiomyocytes. So we say that the dihydropyridines, they are selective for the L-type voltage-gated calcium channels in vascular smooth muscle cells, and I'll abbreviate vascular smooth muscle cells down to VSMC, V for vascular, SMC for smooth muscle cells. Okay, so these are very good at blocking L-type voltage-gated calcium channels in vascular smooth muscle cells, and that's why they have decent effects at lowering blood pressure, because they can cause relaxation of the vascular smooth muscle cells, and that will cause vasodilatation. Vasodilatation allows more blood to move back from the arterial side to the venous side, lowering blood pressure. Okay, the phenylalkylamines and the benzodiazepines are the types of calcium channel blockers, L-type voltage-gated calcium channel blockers, that we're actually going to use as antiarrhythmic drugs, because they're going to block well the L-type voltage-gated calcium channels in the heart. Okay, so the main example then of a phenylalkylamine is the famous drug verapamil. Okay, and the phenylalkylamine class of L-type voltage-gated calcium channel blockers are said to be cardiac selective. Okay, they are selective for the L-type voltage-gated calcium channels that are in cardiomyocyte cell membranes over those L-type voltage-gated calcium channels which I've just described to you that are in vascular smooth muscle cell membranes. So that's the major difference then between dihydropyridine blockers of L-type voltage-gated calcium channels and phenylalkylamine L-type voltage-gated calcium channel blockers, which tissues they are selective for. Benzodiazepines, of which the main example is the drug diltiazem, they are somewhere in the middle. They block well both the L-type voltage-gated calcium channels in cardiomyocytes and also the L-type voltage-gated calcium channels in vascular smooth muscle cell membranes. So diltiazem can be used also, like verapamil, as an antiarrhythmic drug. So these two then, phenylalkylamines and benzodiazepines, of which the main two examples are verapamil and diltiazem respectively, these are used to block L-type voltage-gated calcium channels in cardiomyocytes, and note we give them at levels where they will not block all the L-type voltage-gated calcium channels in cardiomyocyte cell membranes. We give them at a level just to block a few, a certain fraction of them. That lowers the amount of positive charge that comes in the upstroke of the action potential in these atrioventricular node cardiomyocytes, which then slows down the conduction of the action potential through the atrioventricular node cardiomyocyte cell membrane, or across the cell membrane rather, and therefore reduces the number of action potentials that can actually be conducted from the atria to the ventricles. Note the fact that this will not affect the upstroke of the action potential in normal cardiomyocytes, those that aren't in the AV node or the sinoatrial node, because they use voltage-gated sodium channels for the upstroke of their action potential. Okay? Right, so that's the means by which these calcium channel blockers, verapamil and diltiazem, these are the two that we can actually use as antiarrhythmic drugs, not these two. You do not use nifedipine or amlodipine. That's the mechanism by which they can actually slow conduction through the AV node. and hence reduce the number of action potentials that are going to pass from the atria to the ventricles. And going back to overall complete the topic, that's how we can stop these atrioectopic beats actually leading to ventricular tachycardia, and which is obviously a much more severe arrhythmia. Okay, yes, we haven't cured it. Catheter ablation would actually cure it. The atria have still got the problem, but the atria having very rapid electrical signals and contraction rates isn't actually too much of a problem. It's the ventricles having tachycardia that is the problem. So as long as we prevent that, then we sustain a good ejection volume from the ventricles, and that will keep you alive. Okay, so we'll have a break here, and in the next video what we'll talk about is atrial flutter and atrial fibrillation.